Welcome everybody to our Q&A on the Aduhelm approval. We'll probably have other ones of these as we get more information. We're sitting in a status right now where a lot of us don't have all the information we would like to have, but of course we're willing to share the experts' opinions and information that we have here at UCSD. So thank you for spending the time today to tune in. And we're delighted to have some of our top Alzheimer's experts from UCSD available to answer questions. Dr. Howard Feldman, the head of the Alzheimer's Disease Cooperative Study, and a neurologist joined us from Canada. Gabe Leger, one of our behavioral neurologists, very well trained from dual fellowship training across Marcel Messelam's esteemed lab in Northwestern, and did his initial training in Canada. And Doug Galasco should be joining us before too long. We'll see if he's in yet, but he might be predisposed for a bit. But Doug, of course, joined us after, he's been a longstanding member of the UC San Diego neurology community, but he came to us from Johns Hopkins. And then myself, James Brewer, director of the Shiley-Marcos Alzheimer's Disease Research Center and chair of the Department of Neurosciences. We're very delighted that Emily Little, director of the program of the Shiley-Marcos Alzheimer's Disease Research Center, and Christina Gigliotti, who is director of programs and outreach at our center, were able to put this together and give you the information that you sought as you called our center. I will start with just a brief overview of kind of where we are, and then we'll quickly turn to questions from the audience. And the request is that you use, can you go to the next slide, Christina? Basically use your raise hand or chat, and we'll try to monitor that as much as possible so that we can we've got quite a few attendees today, so it'll have to be kind of organized. And we will record this presentation and make it available on our YouTube channel for others as well. And then we'll try to answer your follow-up questions using the participate@ucsd.edu email address. So with that, I'm going to start with just a little bit of a briefing on where we are over this past couple weeks with the approval of Adukanymab, the drug that you've heard about in the news. Is an infusion. Thank you for that overview. Basically on June 7th, US FDA granted what's called a conditional approval under an expedited process to a drug called Adukanymab, also known as Aduhelm. This is a medication that they looked at the data about, and you're going to see that there was a lot of controversy, and we're going to go into some of that with our panelists. But the state of the field is that it is approved, and now the field is trying to understand how we would go about and under what conditions we would decide to administer such a medication. This is a monoclonal antibody, so it means it's a medication that is infused, given by intravenous infusion to remove amyloid from the brain. And as you recall, amyloid is one of the two main proteins that has been associated with Alzheimer's disease, amyloid and tau. Amyloid being kind of the first protein that seems to go awry and begin depositing in the brains of patients with Alzheimer's disease. It's quite unclear the full linkage between amyloid deposition and subsequent cognitive decline and neurodegeneration. But there has been a number of treatment approaches that have attempted to hit the amyloid approach, the amyloid deposition approach, and many of those were using monoclonal antibodies, which did remove amyloid but did not change the clinical course of disease. This one did remove amyloid quite effectively and may have had a signal in one of the subgroups of two large studies that were done. So that's where the controversy comes in, and Howard has a nice summary of kind of the different discussions that were in place, and maybe we'll go into that with him. But in the end, the FDA overruled the group of statisticians who felt like the data were not strong enough to warrant approval. and the FDA gave it a conditional approval, meaning that this is an approval meant for drugs that treat serious diseases, and yet where there is not, where they think there's reasonable chance that it is impacting the course of the illness, but there is still uncertainty about its ultimate effectiveness. And that was the approach by which the FDA used to approve this medication. It now comes to be available to physicians. However, there's many more hurdles to cross. That is, it has to be distributed to the different pharmacies to be able to be infused using an infusion center at each of the different places that would administer it. It also is uncertain how it will be paid for. It is a medication that has been set at a price level of $56,000 per year just for the medication, and the infusion services are also quite expensive. So at least our local site is thinking that the yearly cost for each patient treated could be $100,000 given the added administration costs. So there's a lot to discuss today. We don't have all the answers in hand, but we do have the experts that have been very engaged in this process, and we're delighted to start opening it up to questions from the audience of our panel that we've assembled. So I think I touched on the very first question in the upper left a bit, and I'll just add to that a little bit. That a monoclonal antibody is essentially trying to mimic the immune system's response at attacking foreign particles, and we can use the processes of the pharmaceutical industry to develop a biologic medication that is like an antibody, trained to remove a targeted protein. And that is really what Aduhelm or Adukanymab does. It's basically an antibody that is meant to attack or identify amyloid and remove it from the brain. Is there any additional flavoring to that anybody would like to add about the specific approach of Aduhelm in removing amyloid? Howard?
Thank you, Jim. I guess one of the points to understand about the trials is that one of the most persuasive pieces of evidence that was gathered from the trials was the removal of amyloid. So PET scans, positron emission tomography scans have been done on a large number of people, and they showed unambiguously that amyloid was consistently removed from the brain. And that is a finding that serves as a fundamental support for the approval of this medicine.
Yep, and that was the part that kind of made it into the label, which I think a lot of the scientists were a little bit taken aback by, because we've known these very impressive curves of removal of amyloid have been seen in the past. It's not the important factor, though. It is really more about clinical decline and whether you're able to impact that. And those curves were far less impressive for this particular medication. Gabe, do you want to take the next question? How is the medicine administered and how frequently?
Thanks, Jim, and thanks for allowing me to be part of this panel as well. We all want to add a little bit to this story, and I think maybe I'll follow up before I answer that particular question with Howard's comments that this particular medication was very effective at removing amyloid from the brain. But as you pointed out at the beginning, and I think we can't point this out enough, and that is that the translation between removing amyloid and a clinical benefit to patients, them either not progressing in their disease or even potentially even getting better, has not really been established. So historically, the FDA has always required us to prove that at least in 2 measures of function or cognition, that patients remain stable or don't decline as quickly with the drug than without. And they've thrown that out of the window this time. They've said, well, we haven't really been able to prove this very convincingly, but we do believe that there's a link between taking away the amyloid and improvement in the long run. But it's that long run that we don't have that data yet. And in a way, this is a really big experiment that's going to cost a lot of money, but one that's based on the notion that taking away amyloid may lead to improvement in function after a long time. So as Jim pointed out, this medication is administered through an IV. So you have to show up to an infusion center. We put you in a big chair. We start an IV, and we give you the medication through an IV line. The infusion itself takes maybe an hour, often a little bit less. And it has the way in which we would pursue this, the way in which it would be done in our center, would be very similar to the way it was done within the clinical trials. So it has to be given every month at approximately 1 month at 1 month intervals. Potentially and we don't have an answer for this either. Potentially for the rest of your life to keep the amyloid away. The trials themselves, the medication was given for approximately a year, and we don't know what it means once we've taken away the amyloid. Whether once we start, if we stop giving the medication, whether the amyloid will come back or not. So these are variables that we don't entirely understand. So the medication is given via an IV in an infusion center, and it's something that will have to be done every month from the point where you start moving forward for some time.
Great. Thanks, Gabe, for that. I think, and you answered a bit about how long does the treatment last. I think that's an interesting question as well, because in fact, it hasn't been described in the label when you would stop. And Doug Galasco's had the interesting point to say, well, let's imagine you do another amyloid scan and you see no evidence of elevated amyloid. Should you continue? And that's an open question. Any thoughts on that, Gabe or Howard?
We have been learning about amyloid in the brain. There was a study published earlier this year with another type of monoclonal antibody called Adukanymab, which is still in development. That was very interesting insofar as they documented persons moving from an amyloid positive state, if I can use such a term, to an amyloid negative state. And within that study, when a person transformed to amyloid negative, they stopped the amyloid therapy. So they actually got away from the idea that you would use it for the rest of your life, but replaced it with a more active management plan, which said, we'll treat with this until your amyloid is gone, then we will stop because there's no reason to continue. Now, our clinicians are going to have to deal with this downstream. So we know from the clinical trials, the infusions have gone 18 months and have a good effect on amyloid. But there are no provisions for amyloid scans to be done regularly or routinely. So it's going to be left to clinician judgment as to how long to treat for and whether to obtain amyloid imaging at some point to make a decision about treatment. So I think that, Jim, you started this by saying there are things we have to learn. I think this is going to be one of the things that we learn. We will learn this. I don't think people will be on this treatment for the rest of their lives.
Yeah, and I think, an interesting point of this question, which as many questions do, that just adds other questions. Gabe, do you want to talk about the fact that the label does not really specify that one would even need to identify the presence of amyloid? But I think, and this is actually something we talked about with some of the recommendations that are coming down from national payer guidelines, and that's going to really depend on what CMS talks about. But I think as a physician, we're likely to want to know whether amyloid is in the brain before we give a person a drug, and that'll dovetail into the next question, which is about serious side effects. So can you tackle both of those, Gabe, about looking at whether the target is present and why one would want to make sure that you're cautious in administering such a drug?
Mm-hmm. So I think when a drug label is made, typically it's made, the label meaning how the drug is supposed to be used, how the FDA specifies that the drug should be used. Typically, these labels are derived from the inclusion criteria that were used for the clinical trials that demonstrated benefit. Now, I'm not sure why the current label, the label as it stands for Adukanymab, why it has not followed this particular approach. The label itself does not specify any, it misses a lot of the inclusion criteria that were required to be part of this trial. Now, this is really important, this particular question, because the reasons why we create these inclusion criteria is to make sure that we're treating the right patients that are going to benefit from the medication. And that we're not going to give the medication to people who are not going to benefit from it, or to people who might have complications from it. The notion of using a medication that takes out amyloid, if you don't have any amyloid, it seems like a non-question. Like, what do you mean? You're going to give me an anti-amyloid drug when I don't have any amyloid? Why would I pay for that? And why would I expose myself to the risks of having such a medication? And I think it makes sense that we should be using the clinical trial criteria in choosing or in offering the medication, in selecting the patients that are going to best benefit from the medication. So our approach will be to do that, to apply as best as we can the clinical criteria that were used for participation in the trial, and to offer the medication to those who want it, who are best suited to potentially benefit from it. I talked about the risk benefit. The risks here is if we give the medication is intended to remove amyloid from the brain. In some circumstances, when there's amyloid, for instance, in the blood vessels, or more amyloid than we anticipated, there can be creation of sort of leaky blood vessels, or even damage of the blood vessels that can lead to swelling and to bleeding within the brain. This is actually fairly consistent. As much as 40% of patients that receive these medications will develop these side effects, these anticipated problems. Nonetheless, although it is 40%, most of the patients who develop this either edema or bleeding, most of them, the problem is detected on MRI, is associated with mild symptoms, for instance, a little bit of headache or nausea, or maybe some dizziness, but very mild symptoms typically. And by adjusting the dose downward, we can, or maintaining a lower dose of the medication before moving forward to higher doses, we can get through this period of swelling and bleeding. The swelling and the bleeding that I'm talking about has been labeled ARIA for amyloid imaging related abnormalities, ARIA. And it's either ARIA E for edema or ARIA H for hemorrhaging, for bleeding. And as I mentioned, although these appear in many patients, in 40%, they're not that severe, and with time and adjustment of the dose, we can get through that period. Because the symptoms are not severe at first, we actually do monitor for the appearance of the edema or the bleeding. So that means that if you're receiving this medication, you would need an MRI before you start getting the treatment, and 2 additional MRIs throughout the study, throughout your treatment, to make sure that you're not developing more severe ARIA. That's another cost to the study. And it also requires that you be able to undergo these MRIs to make sure that the ARIA is not severe and is not shouldn't restrict you getting the medication. So a lot of other considerations here, having to undergo an MRI before and during the treatment period, and the potential development of bleeding in your brain, something that I think we're all worried about, yet something that the studies have shown that we can get through by adjusting the dosing.
Great. Yeah, no, that's very thoughtful and very helpful, Gabe, for that discussion of ARIA. And it does bring in that concept of how do you feel if we needed to give this medication to a patient who's either severely claustrophobic or has other, pacemaker or other metal in the body that makes an MRI contraindicated. This has not been really given, we've not been given the great guidelines on this. And in fact, I believe the label noted 2 MRIs, one at week 7 and one at week 12, or sorry, infusion 7 and infusion 12. And there was even discussion, and Gabe, you noted, yes, get an MRI at the beginning. I completely agree, because if a person has microhemorrhages, I would not administer this medication if it looks like they're likely to bleed when giving this medication, or at least it would go into your risk-benefit calculation. And yet I don't believe that was specified in the label, but I think we at UCSD would definitely argue for a pre-MRI to note it.
We have a question from the audience here about how many infusion sites we anticipate.
Right. So I can't speak for other centers. I know, and again, we're in that phase of information gathering where some of it's rumor and some of it's none of it's very formal guidelines that are being brought down. We're kind of hearing that some of our partner institutions have said, the ones that kind of co-insure their patients, where they're on the hook for the dollars in addition to the care, have essentially taken a look at the risk benefit and said, we're not going to give this medication, so you should present yourself to an ADRC. That was actually stated in the Kaiser policy. I'll just say it, that and we were kind of shocked or taken aback at that, and saying we at the Shiley-Marcos ADRC are not an infusion site. Our Center for Brain Health and Memory Disorders, our clinic, is likely to be an infusion site or use our UCSD infusion center. The ADRC is the Alzheimer's Disease Research Center, ADRC, which is a research organization that's putting on this talk right now. It's a great partner to our clinic, but it is not where we deliver care. We deliver evaluations and we offer research opportunities in our ADRC, but it's not where we deliver care. We do full evaluations in the service of advancing the fight against Alzheimer's disease. It's not a place where we would say, unless there was a trial that we were running, would we administer a drug through partnership with the ADRC. But our Center for Brain Health and Memory Disorders, where Gabe practices, where Chris Nissanen practices, where Liz Bevan practices, where Doug Glasgow practices, where Ian Neal practices, and where we have a great coordinated set of practitioners across social work and nurse practitioner, and soon to be adding a nurse. That is the place where we've tried to make the optimal delivery of care programs, including the administration of medications or support, which I still call treatment. I think I've said it many times that our management of an individual through this journey of Alzheimer's disease is very much delivering of treatment, because we are helping that patient and the family avoid devastating either financial decisions or driving decisions or other social decisions that are very important to be aware about before, and we as physicians partner with the patient and the family as that journey goes forward. The ADRC has a different purpose. The ADRC is really meant to facilitate research and outreach and education of the community. So but they do work hand in hand. And so at least in terms of infusion sites at UCSD, they're likely to be just either one or two, the one at La Jolla and possibly in the future opportunity at Hillcrest, but mostly it would be at the Cancer Center Infusion Center, and they are looking into their processes about how they would deliver this medication. The pipelines of delivery has not been established yet, but we expect, even in the coming weeks, to be aware of what the Biogen pipeline for delivering medication to our pharmacy is, and Gabe put in a formulary request to at least get them really started on that, and we appreciate that work of Gabe's efforts. So those are kind of I guess that answers the question about how many infusion sites you anticipate. I don't know across the country, but in San Diego, we know we will be an infusion site. We will be very cautious and very much in partnership with the patient and the family in terms of letting all the risk versus benefit, which is, I think any scientist that saw the data says the benefit is pretty modest. So this question about will this, what are the benefits? It's pretty modest benefit, if even present. And the risks are there. So it'll be a very personal decision between you in partnership with your neurologist and in partnership with your primary care doctor. I always feel like the optimal team of care is a primary care doctor that knows that patient very, very well and knows the personal situation, and then making use of the specialists in our center to help in guiding what would be right for you in a personal situation. So that's where I would take that on that first question. Gabe, do you want to take the next one? What do you look for in the spinal fluid when testing for Alzheimer's?
Well, we look for amyloid. As you may know, Alzheimer's disease is identified after people pass. We can identify that Alzheimer's disease was present by finding abnormalities in the tissues in the brain. The main two abnormalities are amyloid, that we call plaques, and tau, that we call tangles. So these abnormalities appear in the brain, and we can see them in the microscope. And that's in fact what Dr. Alzheimer found when he reported his very first patient with what was going to be at some point called Alzheimer's disease. Well, we can measure those two abnormalities, those two proteins. We can measure them in the spinal fluid. We do a spinal tap. It's a very simple procedure that we do in the clinic at the bedside, if you will, where we draw a little bit of fluid and we send it for very special analysis to determine how much amyloid there is in the fluid and how much tau there is. And that the combination of those two measurements confirm to some extent. They don't absolutely confirm that the patient's difficulties with memory are absolutely the consequence of Alzheimer's disease, but you can't diagnose Alzheimer's disease without having those changes take place. I'll add that in the clinic, we spend a lot of time sort of thinking about, well, we don't see Alzheimer's disease. We see patients that have problems with their memory. And we look for or try to demonstrate that Alzheimer's disease is one of the causes or the main cause of their memory problems. But patients often have many other factors that lead to the memory loss. And sometimes Alzheimer's disease is something that's going to appear in the future that isn't actually present yet. The biological changes that lead to Alzheimer's disease are present, but they're not present to the extent that they're causing the symptoms. There are other things causing the symptoms: depression, sleep apnea, maybe stroke, maybe other issues that we haven't considered. So that's why I think it's really important that patients that are thinking about getting this kind of treatment, that we establish that Alzheimer's disease is indeed present and indeed the main cause of the memory problems. Otherwise, treating it like this won't really lead to any clinical improvement. And that's where the spinal tap, I think, is very important to determine that we're actually dealing with Alzheimer's.
That's
The
great.
spinal tap is, sorry, Jim. The spinal tap is one of the ways in which we can determine amyloid status, determine that the patient has amyloid. But there are others that are being developed. There's the PET scan, which we heard about already, which can prove that there's amyloid in a person's brain. And there are going to be blood tests. They're down the line, presumably in the next year or two, these will become available and will be FDA approved for confirming that there is an amyloid process and that Alzheimer's is probably present. But we're not quite there yet with those other tests. So spinal tap is the way we tend to do it these days, but in the future there will be alternatives.
Great. I appreciate that, Gabe. And just to build on that, it's unfortunate Doug is off in clinic now, taking care of patients, so he wasn't able to join today, but it's really his specialty, looking at spinal fluid markers of Alzheimer's disease beyond amyloid and tau, which is used in the clinic. Doug has been really advancing our status among the nation's top biofluid research organizations, because we get spinal fluid within our Shiley-Marcos ADRC, and have really pushed other markers. And as well as Howard has been bringing in novel biomarkers across his studies. Howard, do you want to just build on that before we go to the next question, which you can also hit, which is about whether Adukanymab was developed at UCSD? But I thought I'd let you talk about biomarkers in general, right, if you wanted to.
Yeah, so I think that the important takeaway here is that this is a targeted type of therapy. This is specific to the presence of amyloid in the brain. As Dr. Leger has mentioned, it only in turn makes sense that this be documented as a target before a person starts receiving this treatment. We do know that there are persons who have dementia and cognitive impairment who do not have brain amyloid disease, and for those people, this is not an appropriate question. There are a lot of other markers in development that we do in research studies. They're not quite ready for prime time yet, but we've learned a lot about them. And again, within the foreseeable lifespan of this product, they may end up turning out to have some utility as a marker of response. But at the moment, that's premature. So the two main markers are amyloid and tau.
Great. And do you want to tackle that question about what our involvement was in this marker, maybe building on some other research that we're doing as well?
Right. So the development of Adukanymab was a very clever idea developed by some scientists in Switzerland. They got the idea of studying persons' blood who had aged successfully, or alternatively had Alzheimer's disease, but very, very mild disease, and it never seemed to progress. And what they did was they reverse engineered to find the magic sauce, so to speak, of what the factor was in the blood and in the brain that helped promote successful outcomes. And then through reverse engineering, mass produced it into Adukanymab as the candidate monoclonal antibody. So a very clever development strategy. So it was not developed in San Diego, but the studies that were done on Adukanymab were global. 348 sites and 20 countries in the world all participated to gather more than 3,000 participants in the studies. Here at UCSD, we had a participating site in one of the trials that was done with Adukanymab. So there's some local experience and a smaller number of persons, but certainly some familiarity with this treatment.
All right, thank you for that. I think it kind of dovetails into possible impacts upon our research. Do we want to delve into that at this point? I think let's make sure we hit some of these other questions here, which is, do you know if other states are planning on infusion centers, or will we need to come to San Diego in the near future? We do not live in California. Howard?
So Jim, maybe I'll make a comment. There was a very large meeting yesterday morning sponsored by the Alzheimer's Association. There were between 2,000 and 4,000 colleagues on the meeting at different times. One of my takeaways from that meeting was that there's a sense that This treatment will require a team to administer. This will not be an easy to administer therapy. And I'm expecting that it will require an infusion center, it will require careful follow-up, access to imaging. So it's going to require a fair amount of sophistication and organization in the environment. We are pointing ourselves through our memory disorders clinic to set up that infrastructure so it's accessible. My guess at a country level is that the same type of pattern is going to unfold, where centers that have more infrastructure will be able to deliver it and hopefully act as hubs to spokes of referring physicians and others that are not that well set up to administer but have potential patients for this administration.
Great. And I think that answers the question, where should I go to receive treatment? So I think that basically there will be more and more options, but we're not quite aware of specifically which sites are offering this medication. The next question, how can I find out if my insurance covers the cost? I'm sure the insurance companies are getting a lot of that question right now. The main payer in this case is Medicare. So we're all waiting the decision by the Center for Medicare Services about whether they are going to cover this. And even if they do, it is likely, unless you have additional insurance, to still be subjected to the 20% copay, which puts the cost at least at $11,000 per year, if you don't have the additional coverage over that. I believe it's the Part B section, but so that's going to be a really thorny issue that comes about for many different reasons. It's an extraordinarily expensive medication. If you do the back of the envelope math on what the estimates have been on what this is going to cost, if Medicare does cover it, it's essentially, if my math is right, it's like asking every man, woman, and child in the United States to give about $300 to the company to manage the large. So it's a very expensive medication. But again, on the other side this is a very devastating illness. If we had a real strong therapy, we would be very willing to shoulder that kind of a societal cost, because the benefits would be huge. The problem is, if you look really closely at the data here, I think we're not super impressed that this is going to really move the needle in terms of the societal cost of Alzheimer's disease. Even in the best case take of this is that it slows. And I always hate that percentage that they note, saying, oh, it's going to slow it by 20-some%. And it's, the disease is such a very slowly progressive illness that slowing it by 20x%, 25, 23%, really means a very, very modest change across a year. But so these are the things that you'll need to interact with your physician, your primary doctor, your specialist doctor, to decide whether this is something that's right for you and your family. And that'll be, not an easy decision, but we'll try to gather as much information as we can to help in making that call together. The next question was related to an individual whose husband neurologist diagnosed with an MRI to have Alzheimer's disease, saying this is not possible now. They can only diagnose through the spinal fluid. They say my husband's hippocampus went down from 85% down to 5% within a year. I think that's related to, will this make my husband's memory come back question, but it's about diagnosis. Gabe, do you want to further follow up on that topic about how different biomarkers show different things?
Sure. Thanks, Jim. So as I mentioned earlier, when we see patients in clinic, we're concerned about why the patient has problems with memory. And we try to rule in, to the extent that we can, try to rule in Alzheimer's disease to show that Alzheimer's disease is the main cause of the difficulties, and choose the therapy appropriately. If there are other things that are involved, then we'll treat those other conditions that we discover, sleep apnea being an example of something that we frequently find in our patients. So the question of how do you diagnose Alzheimer's disease? Well, the main way to diagnose Alzheimer's disease is after death. after we can look at the brain and see that there was the changes that we talked about, the amyloid and the tau and a number of other changes. But we're not in the habit of doing that when people are alive. So we look for other changes that can occur. Determining the presence or absence of amyloid has not been simple up to this point. One way of doing it is via a spinal tap, as we've been talking about. And again, we're not in the habit of doing that as frequently as we would like, because it is a little bit invasive. So what other changes can occur in the brain that might lead us to think, oh, this might very well be Alzheimer's disease? Well, it turns out that the memory centers themselves, the center is called the hippocampi or hippocampus. You have hippocampus is singular, hippocampi is plural. You have two. So your hippocampi in Alzheimer's disease shrink. They become smaller, and we can detect that change. We can detect that they are smaller than they should be using MRI. Not everybody with Alzheimer's disease has small hippocampi though, so it's not a perfect test, but in the presence of very small hippocampi and the presence of memory difficulties, without any other conditions leading to that we think might be contributing to the memory problems, we're more confident that we're dealing with Alzheimer's disease. So that's the context in which a doctor might look at a scan and say, your memory centers are very small and you have memory problems, but nothing else that I can see that can cause the memory problems, then this is very likely to be Alzheimer's disease. And they would be right. But we could confirm that by doing a spinal tap and looking for amyloid. We just don't do it regularly because it is a bit more invasive, and it doesn't really, once we're confident enough with the MRI, we can usually move forward after that. The situation is different here in that if we're giving an anti-amyloid drug, we want to be sure that there's amyloid. So the context is changing. And in a way, this new setting that we want to determine whether amyloid is present or not is probably going to lead to us finding out that there are patients who have small hippocampi who we think have Alzheimer's disease, but don't really. They have something else. And that's going to open the door to probably new forms of research and new discovery.
Excellent, Gabe. That was really nicely laid out. I think that was clear. So the next question is about the controversy here. So the fact that the FDA barely approved the medication and the controversies around it, does it make any additional steps taken to administer the meds, make it a continuation of studies rather than a comfortable solution to be used? Should patients be skeptical? Howard, do you want to take on that question?
Sure. Jim, I'm just wondering if it might be useful to actually take a moment and look at the last slide in this slide deck at what the trials taught us, because it does help shape expectations of what this treatment might do. So not that one. I think we're going to go right to the back. It looked like it was right there. Perfect. So these are two studies that were undertaken. The graphs relate to each study. The top study went by the acronym EMERGE. The bottom study went by the acronym ENGAGE. What you can see is that there is a primary outcome measure, which is called the clinical dementia rating, which is an aggregate, a composite measure of how people are doing in cognitive function and everyday function in the community. And scores are worse when they get larger. So what you can see here is that all of the curves in both of the studies get worse over 78 weeks. So on the x-axis, we're looking between 0 and 78 weeks on each graph. And that purple little star in EMERGE indicates that there was some benefit. So the gray group, which was placebo, did worse than the other treatment arms. But as you can appreciate, if you look at the y-axis, the actual differences were relatively small. So small differences, but significant. And here's where the controversy came in. If you look at the same outcome in ENGAGE, there was no significant benefit. So what that tells us, and the same applies to each of the measures down the line. So what that tells us is that one study was positive, one study was negative, and that really is the heart of the controversy without getting into a lot of other inside baseball discussions. But that was really the controversy. The effects were small, and only one of two studies was positive. Some argued that they should be asked to do a third study. Others argued a third study would take between 5 to 10 years to do and would be way too long. And there was enough promising results in eMERGE that that would serve as the basis for approval. In the end, the FDA decided to approve it, and they did it slightly differently, not on the basis of these graphs, but on the basis of removing amyloid in the brain. And I think a lot of us were surprised by that decision. So standing back from all of this, it's been 20 years, nearly 20 years since there was an approved treatment for Alzheimer's. This is perhaps amongst the most promising data that we've seen. If you look at it in aggregate, it's not as strong as we would like it to be. We still remain to be convinced that were we to do a third study, we get the same result as eMERGE. We don't know that. We hope that. We also hope that by clearing amyloid, there's a long-term benefit. So the limitation here is that this is 1.5 years of treatment. We are hopeful that if you were to go out 4 or 5 years, these curves would really separate. But it's speculation. And for those of you that are affected by the disease today, you're looking for something today. And you know, the hope that maybe there will be benefit is a hope that we share, but we don't have that certainty. So Jim, that's really the basis of a lot of this controversy. There's no way to simplify it. The question about will they plan to go out 4 to 5 years? Yes, they will, but they've already been allowed 9 years to show the 4 to 5 year study. So it's going to be a long process. We'll have to be learning along the way.
That's a great summary, and I'm glad you brought up those curves, because I think those curves really tell the story that, there were questions that were into place here. The medication slows down the progression of disease, but is not able to reverse the effects, correct? And I guess you would say it definitely is not showing a reversal to improvement from before enrollment. These are all individuals that had some impairment even at that baseline that starts at 0. And we definitely don't go beyond that 0 and start going better. So that answers that question. And the question is, does it slow down the progression of disease? It kind of depends on where you look at this data. A hint of it in eMERGE, not a hint of it in ENGAGE, really. And that's the thing that's kind of disappointing for us. We'd love if this kind of investment of society is going to be made, that we'd like it to be on a medication that actually is the one that we would be delighted to prescribe. That's not what the hand we've been dealt. We are given this medication with its warts and all, and its side effects and all. And that's why this becomes a very personal decision between you and your physician and your family, in fact, as you think about rating the, possibly some copays that could raid significant savings of the family. And that's one of the things that we as physicians want to also consider in the personal situation is first do no harm means first do no harm to the entirety of your personal situation. So those are the challenges and the struggles. And that's why I think we're delighted to have assembled such an expert team of specialists here at UCSD. It's a place that draws some of the top minds, and we're delighted that that's the case here. It is very, very difficult to recruit individuals in this specialty. It's a very demanding specialty. It's been a very disheartening specialty in a lot of ways. Although again, I do, because it's been 20 years since a drug has been approved to make an impact on the progression of the disease, it's very frustrating for patients and families and physicians. Although we are here to help in managing the journey, and this is yet another tool in our toolbox to be able to help in making decisions on how an individual engages with us in administering drugs or not, but we will still be here to administer what we call treatment. That is the management of your symptoms and helping support your family through the journey. I think if there are other questions, we've got a few moments left for free form. There was an interesting question about mitochondria. I think that's a great topic to extend from, because again, what I've always said is that what this medication might do, despite significant impacts on the field and maybe burning some of our resources that we would like to give toward discovery of new home run therapies, it will show that these people that are progressing to severe disease don't have detectable amyloid based on our biomarker tests. Essentially, these people are having amyloid removed from their brain, and yet they continue to progress. And I hope that brings the field to a new state of saying, let's look at some other markers and let's look at other processes. Let's look at some other pathological features of this disease, including the topic that was brought up, mitochondria, the aging process, the inflammation that is seen in the brain as a reaction of the brain to the process of Alzheimer's disease. There's many, many topics within this disease that I think need to now be focused upon as we see people continue to progress despite amyloid removal. So the question was, is there any research being done on those who have Alzheimer's on the mitochondria in the brain? And I think it's a great question, because we think that mitochondria are one of the features that tend to change with aging. They are sitting there within the cell. They need to be the energy machines of the cell, and they may be one of the places where that starts to fail as an individual ages. And we have the blessing of two really strong scientists in mitochondrial research, Zhang Ro, who is an epilepsy doc, but is interested in the function of mitochondria in the brain as it relates not only to epilepsy, but to aging in general. So he's a visionary leader in our department. And then a partner department, geriatrics, and also this individual has a joint appointment with neurosciences, Anthony Molina, who is really at the forefront of understanding the changes of mitochondrial function with aging.
Gabe, maybe you want to talk about the site and other things that you're involved with here.
Maybe I can follow up on a couple of other studies that we're doing here at the ADRC and through our clinical trials unit. But as Dr. Brewer pointed out, we were part of the ENGAGE and eMERGE studies. We were one of the sites giving Adukanymab when it was being tested. We have other drugs that address other aspects of Alzheimer's disease, including drugs that act against tau, this other classic marker that's found in the brains of patients with Alzheimer's disease. So anti-tau antibodies is one of our clinical trial. We have another very young, very early phase study, a phase 1 study, where we're looking at gene therapy in Alzheimer's disease. So modifying certain cells in the brain so that they secrete a factor that helps promote cellular health and helps the cells in the brain that are being damaged by Alzheimer's, helps them survive better and longer, and in fact make new connections. So there's a lot of different approaches to Alzheimer's disease, not just amyloid. And I think, as Dr. Feldman pointed out, we're not going to cure this disease with a single bullet. We're going to need a lot more, and we're going to need to be combining these different treatment modalities. And we won't figure out how to do that unless we continue to do these clinical trials.
Thanks for that. That's a great summary. I would say we at the ADRC have said it many times. We see the participants of this in our studies to be the heroes of this fight against Alzheimer's disease. You're willing to give your time and your comfort to our center. And two of the particular groups we have a remarkable need for are the patients with mild cognitive impairment. We'd very much love to see individuals enrolling in our studies. We have many, many individuals doing research that are either observational or interventional at that stage of illness. We have more studies then we have participants. So there are more opportunities than we have participants. So we'd love to have more participants come in. The question is about, and you see the answer to the question about how we choose people to be in studies, in trials. We're also very interested in the diversity aspects of this disease. We're looking at recruitment of Latinos particularly, and also Howard has a new study that is going to launch within Asian American Pacific Islanders, I believe, the Vietnamese community, and that's a very exciting new opportunity. So these are areas we'd really love to see you contact us and stay engaged with us. We're working on our registry so we can be better engaged with this group. Please do reach out to us at clinical trials ADRC at ucsd.edu. Come to our center's website, adrc.ucsd.edu, to learn more. Get on our registry, even if you're not in the longitudinal study, and we'll try to keep you updated. And we'd love to have your continued engagement. Thank you so much for spending your time with us today, and we look forward to continued interactions with you.